Hello, this is Dr. Kodev, and this is chapter 14 in your Martini Human Anatomy book, the nervous system, specifically the spinal cord and the spinal nerves. Features of the spinal cord. So we're going to see that it's 45 centimeters in length, passes through the foramen magnum, that big hole in the skull, and extends from the brain, and it ends at about L1, L2. So lumbar vertebra 1 or 2, and then it becomes what we call the cauda equina. So the cord itself is from the brain down to L1, L2. There is a neck region called the cervical region. The mid-back area is called the thoracic region. The low back area is called the lumbar region. The tailbone area is the sacral and coccygeal region. Features of the spinal cord, we see a transverse view, white matter, gray matter, the central canal, dorsal root and ventral root. These are going to merge to form a spinal nerve. And the dorsal root is sensory afferent dorsal. Axons extend from the soma within the dorsal root ganglion or the cell bodies. And the ventral root is motor. So that's the sensory afferent dorsal component that we saw in the last chapter. And here is a picture for you. So right here is the posterior area or dorsal area. So this is sensory afferent dorsal territory right here. This is the central canal. We saw that last chapter. It's filled with cerebral spinal fluid. And then surrounding the cord is cerebral spinal fluid as well. This is the dorsal root ganglion. Remember, ganglion is a collection of cell bodies outside of the central nervous system. Cell bodies in the central nervous system are considered nuclei. So this is periphery here. This is central here. Okay. So sensory information comes in through here. Let's say it's touch, pain, temperature, then it's going to synapse here, cross over the cord and come up a certain pathway. So we look here, get a different color here. This is going to be motor territory coming from the ventral aspect. Okay, so this is a section of the cervical cord here, thoracic, lumbar, and sacral. The spinal nerves consist of sensory or afferent and transmit impulses towards the spinal cord. Our motor nerves create movement, so it transmits impulses away from the spinal cord. We'll see meninges, specialized membranes that provide protection, physical stability, and shock absorption. It's continuous with the cranial cerebral meninges. The denticulate ligaments help anchor the spinal cord in position. And we've got these three layers padding the brain, PAD. Innermost layer, pia. Middle layer, arachnoid, like spider webbing, arachnoid. And then outer layer is dura, as in durable. So pia is very thin, innermost layer. Arachnoid is kind of the spider webby layer. And then dura is the most durable outermost layer. And you can see them right here. So dura matter right here, very durable. Arachnoid matter is here, and it's going to look kind of like a spider web. And then the pia matter right here looks very much like just a very thin layer of saran wrap. And you can see the dorsal root here, that little bump out of the cell bodies here. And then you can see, let me move a couple things here. The ventral root is for motor information right here. Let me get a better color on the screen. So the ventral root is motor. And then we see white matter here on the outer areas of the spinal cord. What makes white matter white? Myelin. And then the gray matter in the center area here, that H shape, that butterfly shape in the middle, that gray area is going to be the cell bodies. This is the front of the body. This is the back of the body. This is showing where someone would do a lumbar puncture to get cerebrospinal fluid out of the spinal canal here. So this is L3 vertebra, L4 vertebra, and the discs in between. And so you want to go well below L1, L2 area because that's where the spinal cord itself ends and becomes the cauda equina. That just looks like horsetail, basically, is what that means. Cauda is tail, equina is horse. So it looks like a little ponytail of nerve fibers coming through here past L1, L2. There's 31 pairs of spinal nerves. We have 8 cervical nerves. Now we have 7 cervical vertebra, but we have 8 cervical nerves. And so we see these vertebra, C6, C7, T1, T2. In between C7 and T1, this area right here, that's where that nerve is going to be. C8 nerve is going to be between that C7 and T1. Okay. We have 12 thoracic nerves, 5 lumbar, 5 sacral, and 1 coccygeal. And you can see the nerves right here. So 7 cervical vertebra, 8 cervical nerves. You can see C8 right there. 12 thoracic, 5 lumbar, 5 sacrum, 1 coccygeal. And you could see that the cord ends at about L1, L2 proper right there. And we call it the conus medullaris as the end of the cord. And then we call it the cauda equina is this horsetail looking appearance to the nerves. We're familiar with these terms. Epi means above or around, peri is always the middle layer, endo is the layer within. And our peripheral nerves are no different. So epineurium is the outer layer. It's continuous with the dura mater, that meninges. Perineurium is the layer surrounding the fascicle or the bundle of axons. Endoneurium, endo means within or the deepest layer in, and that's surrounding the single axon. And you can see the layers here. So we're looking at this space right here. Okay. You can see the little blood vessels, artery in red, vein in blue. Epineurium is going to be this outermost layer here, epi, covering that whole peripheral nerve. Perineurium is around one fascicle. Okay, so around one fascicle. Endoneurium is going to be this little one right here. Okay, perineurium is around the bundle of wires, and then the endoneurium is just the one wire. Dermatomes. Derm means skin, so the skin that's innervated by these spinal nerves. And each pair of spinal nerves monitors specific surface area, and these are extremely clinically important when we're talking about numbness, tingling, things happening in the spine. And so we see C4 area here, C5 right here, 6, 7 is going to be towards the middle finger and the pointer finger. You can see here. And then C8 is going to be further this way. T1 is going to be into this territory. You'll see different resources saying different things. So sometimes you'll see that the pointer finger is C6. Sometimes you'll see that the pointer finger is C7. It's both. And so it's usually innervated by a little bit of both. There's a lot of redundancy in the nervous system, meaning that nerves are going to innervate multiple nerves are going to innervate areas. So we have these plexi or plexuses, or plexus would be the singular, and we have a neck one, an arm one, a low back, and a sacral one. And sometimes we call it the lumbosacral. So we'll call it the lumbosacral here. So for example, here's the brachial plexus. And we're going to talk about these. I know it's a lot, but I'll take you through it. And so what we're looking at here is the vertebra, right? So we see 5 and we see the C5 nerve right here. Hold on, let me get that better. C5 nerve right here, C6, 7, C8, okay? T1, here's the first rib, okay? And so we're looking and we see all these nerves. And the way to look at this is this color-coded key over here. And we have roots, trunks, divisions, cords, and these peripheral nerves or branches. Okay, sometimes these are called branches. Okay. And so we see the roots over here in the purple, trunk in the green, divisions here, cords here, and these peripheral nerves or these branches out towards the perimeter here. And I have a little activity for us to do that will help you with this component. So in the very next slide in your slide deck notes here, you have a very similar picture to this. This is a video for you to pause and play. Right? It's about, I think it's about 7 minutes or so, 7.5 minutes, to pause and play and draw on that slide deck. Okay, so you can expand that picture and maybe use whatever you like to use, maybe Notability, and draw on that slide deck to try and help you out with understanding this. So I'm going to go ahead and play this video.
Learn the essentials of the brachial plexus. Here we'll learn the essentials of the brachial plexus. First, draw 3 horizontal lines. Label them from top to bottom as the upper, middle, and lower trunks. The upper and lower trunks are often referred to as the superior and inferior trunks respectively. Then indicate that C5 and C6 form the upper trunk. C8 and T1 form the lower trunk, and C7 makes up the middle trunk. The brachial plexus is typically formed from the C5 to T1 ventral rami. Now show that the trunks divide into interior and posterior divisions as follows. The posterior divisions all join to form the posterior cord, which forms the radial nerve. Indicate that it innervates extensor musculature. And also show that the posterior cord forms the axillary nerve. It's responsible for shoulder abduction most notably. Indicate that the anterior division of the lower trunk forms the medial cord, which forms the ulnar nerve and a portion of the median nerve. Write that the ulnar nerve innervates medial flexors that lie below the elbow. Medial refers to the pinky side of the hand. Then show that the anterior divisions of the upper and middle trunks form the lateral cord, which forms the musculocutaneous nerve. It innervates the biceps brachii most notably. Now indicate that branches from the lateral and medial cords join to form the median nerve. Indicate that it innervates lateral flexors that lie below the elbow. Lateral refers to the thumb side of the hand. With this key innervation in place, let's switch to an anatomical diagram so we can understand the general position of the plexus and these terminal nerves within the neck and upper extremity. Draw the most posterior structures first, the scapula, then the posterior aspect of the first rib, then the vertebral bodies of levels C4, C5, C6, C7, and T1. Show that the C5, C6, and C7 nerve roots lie above their corresponding vertebrae. And then because there isn't a C8 vertebra, that nerve root lies above T1, so the T1 nerve root has to lie below its vertebra. Next, draw the humerus laterally, the clavicle superiorly. We cut away the medial portion of the clavicle so we can see the plexus below it. Typically, the divisions lie beneath the clavicle. Then the sternum medially. Also include the coracobrachialis muscle in the supromedial shoulder. It's an important landmark. Now let's draw the brachial plexus components we've shown so far in our innervation diagram. The upper trunk from C5 and C6, which forms the musculocutaneous nerve, which extends out laterally and penetrates the coracobrachialis muscle to ultimately run underneath the biceps brachii, which it innervates. Show that C7 forms the middle trunk. Its anterior division joins the lateral cord. Show that C8 and T1 form the lower trunk, which runs down the medial aspect of the arm and ultimately becomes the ulnar nerve. Now indicate Erb's point, where C5 and C6 come together. Indicate that Erb's palsy, which is also known as Erb-Duchenne palsy, is an upper trunk plexopathy, and then that Klumpke's palsy is a lower trunk plexopathy. They occur from trauma, such as birth trauma, which more commonly causes an Erb's palsy rather than a Klumpke's palsy. Indicate that Erb's palsy produces a waiter's tip deficit, which pictorializes the arm being at the side and pronated, the hands ready to receive the tip. Klumpke's palsy produces claw hand, wherein the metacarpal phalangeal joints extend and the proximal interphalangeal joints flex like a claw. It affects both ulnar and distal median nerve musculature, so all fingers are affected. Then show that the posterior cord forms from posterior divisions of all three trunks and extends laterally and posteriorly to form the radial nerve. Indicate that the radial nerve runs within the spiral groove on the posterior aspect of the humerus. It wraps back around anteriorly in the distal humerus. Then show that the axillary nerve exits the axilla posteriorly through the quadrilateral space to wrap around the humerus and innervate the deltoid. Notably, the posterior circumflex artery joins it in this space. Next, show that the median nerve forms from the lateral and medial cord branches and runs medial to the humerus, but lateral to the ulnar nerve. Then draw the axillary artery, which is a continuation of the subclavian artery. Specifically show that it climbs over the first rib, passes over the posterior cord, but beneath the lateral and medial cords. As we can see, the cords are named by their relationship to the axillary artery, specifically the second portion of it. The lateral cord lies lateral, the posterior cord lies posterior, and the medial cord lies medial. Indicate thoracic outlet syndrome, which most notably occurs from a cervical rib. It affects the lower trunk and therefore can produce a claw hand like Klumpke's palsy, and can also cause vascular compression signs like edema and arm discoloration from subclavian artery compression. Now show that C5, C6, and C7 derive the long thoracic nerve, which innervates the serratus anterior muscle. It pulls the scapula forward, it protracts it, opposite to the rhomboids. Indicates scapular winging, wherein there's prominence of the infromedial border of the scapula, most commonly from long thoracic nerve injury, and resultant serratus anterior weakness. Note that the long thoracic nerve is derived directly from the nerve roots themselves, but not from the brachial plexus, which means that in a pure brachial plexopathy, the serratus anterior is spared. Now draw the medial brachial cutaneous and medial antebrachial cutaneous nerves. They're sensory nerves that cover the medial aspect of the upper arm and forearm, respectively. In ulnar nerve injuries, medial arm and forearm sensation is spared due to sparing of these cutaneous nerves. This concludes the essentials portion of our brachial plexus.
Excellent. So make sure you take some time with that and pause and rewind as many times as you need in order to kind of get through it at least once to where you can kind of draw it out a little bit. That should be helpful to you. Hang on, and we'll get right back to our PowerPoint here. So that is sitting right there in your slide deck. for you to be able to draw this out along with that video. We'll do one more together here. So we're going to look at the lumbosacral plexus. And even though it says lumbar, it does start at T12. So the last of the thoracic area. So T12 to S4, also called the lumbosacral plexus. And we're going to go ahead and take a look at some of these nerves: genitofemoral, lateral femoral cutaneous, femoral nerve, sacral plexus nerve, including the sciatic nerve and fibular and tibial divisions of the sciatic nerve. So we will take a look at that. And this is T12 right here, L1, L2, L3, L4, L5. And you can see it has that same kind of weird wiring system. Again, that redundancy is on purpose in case there's an injury somewhere. Let's say there's an injury to this nerve going here. Well, this one, this here, there's a lot of redundancy, right? So if there's injury to one component of a nerve, there's a lot of overlap. So hopefully the nervous system will still be able to do its job. I liken it to a main highway and then the side streets. Okay, so you can take a look at this, kind of draw it out a couple of times, and then we're going to look at this. So this is the activity. So I'm going to move over to that screen. So hang on to this slide here. Pause as many times as you need to, and I'll load that up for you. Okay, so you have a very similar picture to this. Same thing, pause and play and rewind as many times as you need to be able to follow
Here
along.
we'll learn the
And let's go.
Here we'll learn the lumbosacral plexus and innervation of the thigh in two different parts. We'll begin with the essentials, and then in the second part, focus on the advanced structures. The challenge in the brachial plexus is its web of connections. Here the challenge is the number of spinal nerves we have to manage. What will help us is for us to generate a diagram that groups the various nerves based on their route out of the pelvis. Draw the lower lumbar vertebral column and sacrum. Specify the L5-S1 junction, a clinically important level for disc herniation. Here the vertebral column angles abruptly posteriorly. Then draw the right pelvic bone, the femur, the superior aspect of the tibial and fibular bones. Then draw the inguinal ligament. Show that the ilioinguinal nerve exits the pelvis over the inguinal ligament to the superior medial portion of the thigh. Next, include a portion of the iliacus laterally and psoas major medially, which together form the iliopsoas. Show that the femoral nerve exits the pelvis, passes in between the psoas and iliacus muscles, underneath the inguinal ligament. Next, draw the sacrospinous ligament. Show that the obturator nerve descends medial to the femoral nerve, anterior to the sacrospinous ligament, and exits via the obturator canal down the medial aspect of the thigh to innervate the medial compartment muscles. Now draw the piriformis muscle, which originates along the sacrum and inserts along the femur. Show that the sciatic nerve exits the pelvis anterior and inferior to the piriformis via the greater sciatic foramen and then descends posterior to the femur. At the inferior femur, show that it divides into the tibial nerve, which continues down the posterior tibia to innervate the posterior leg and plantar foot, and the peroneal nerve, which wraps around the fibular neck and innervates the anterior and lateral leg and dorsal foot. Next, let's address hip and pelvis innervation from the lumbosacral plexus. First, indicate that spinal nerves L1 to S4 form the lumbosacral plexus. Show that the sciatic nerve is derived from L4 to S3. Then that the femoral and obturator nerves are derived from L2 to L4. Indicate that the sciatic innervates the hamstrings, which provide hip extension. Then that the femoral nerve innervates iliopsoas, which provides hip flexion. It's key to climbing upstairs or rising from a low chair. Now for thigh innervation. Indicate that the thigh divides into 3 compartments. The femoral nerve innervates the anterior compartment. The obturator nerve innervates the medial compartment. The sciatic nerve innervates the posterior compartment. The one compartment, one nerve principle helps us remember each compartment's innervation and function. Next, show that we'll establish the key muscles, roots, and actions of each of these nerves. First, indicate that the femoral nerve innervates the quadriceps femoris muscles, which are rectus femoris and the vastus muscles, vastus medialis, vastus intermedius, and vastus lateralis. They provide knee extension, which is key to walking downstairs. Then for comparison, repeat that it innervates the iliopsoas muscle, which comprises iliacus and the psoas major and minor muscles. The psoas muscles are innervated by direct branches from L1 to L3. They provide hip flexion, again, key to climbing upstairs or rising from a low chair. Next, show that the obturator nerve innervates the adductor muscles, which are adductor longus, adductor brevis, and adductor magnus. Note that adductor magnus is also supplied by the sciatic nerve, as we'll show later. Show that they provide hip adduction. Indicate that the adductor muscles also provide a variety of actions intrinsic to gait and stability. Now show that the sciatic nerve innervates the hamstrings muscles, which are semimembranosus, semitendinosus, and the short and long heads of the biceps femoris muscle. Note that the perineal division of the sciatic nerve innervates the short head of the biceps femoris, and that the tibial division innervates the other hamstring muscles, the long head of biceps femoris, semitendinosus, and semimembranosus. The perineal innervation of the short head of the biceps femoris is especially important in localization because of perineal neuropathy of the fibular head, the most common perineal nerve entrapment site, will spare the short head of biceps femoris. Now show the sciatic nerve's innervation to the adductor magnus muscle supplied by L4 and L5. Indicate that the hamstrings and adductor magnus provide knee flexion and hip extension. Before we conclude, let's consider the anatomical relationships of the neurovascular structures of the femoral triangle. They're critical to know when performing femoral venous cannulation. Within the femoral triangle, the nerve lies most laterally. Medial to it is the artery, and medial to it is the vein. The mnemonic NAVY is helpful because it incorporates the position of the midline genitalia, the Y, into the acronym. This concludes the essentials portion of our lumbosacral plexus.
Great. Hopefully that helped and you took the time to work on that. I have one more video for you. It's just over 16 minutes, almost 17 minutes long. And there are a lot of videos at this website that I would love for you to check out to help your studies over the next couple of weeks about the nervous system. She does a really great job of explaining things and uses a lot of plastic models and dissection models, cadavers as well. And does a really great job. So this is going to talk a little bit more about the spinal cord that we touched on, and that will conclude our presentation for this chapter. And I'll post the link on your Canvas page, but it's also in your slide deck of notes. So here we go. The first part is silent, but it will start speaking in a moment.
Today we're going to talk about the spinal cord, and I brought along my friend here to help tell you some of the salient features and to show you the spine in the real skeleton. So let's turn about and have an about face and look at the spinous processes along the vertebra And we're not going to go into the details about how many cervical, thoracic, lumbar, and sacral segments there are, because you've already learned that. What I want to emphasize is the relationship between the vertebra and the canal where the spinal cord runs. So let's put the brain back in our model here. And this is a brain with the spinal cord still attached. And what I want you to realize, I'm going to put this in front like this, is that the spinal cord comes down and ends right about here, where my thumb is, at about L1. And below that, you have these rootlets of the cauda equina that continue on down through the canal and inside the dural sac down into the sacral region. And then these roots, sensory and motor, emerge from the foramina that are along the vertebra or in the sacrum. And therefore, if you're going to remove cerebrospinal fluid, you want to do it down fairly low at about L4, L3, and that region. So let's go now and look at a plastic model showing the roots. So here is a plastic model of the vertebral column with the pelvis attached. And while we're looking at the cervical region with the bones of the vertebra here, I want you to take note of the red vertebral artery on either side. The vertebral artery comes up through the foramina in the sides here of the cervical vertebra and then enters through the foramen magnum, that's this hole right here, to form the two vertebral arteries on the medulla and then join to form the basilar artery. When we talk about the vascular supply to the brain, it will be important to remember that this part of the circulatory system, the vertebral basilar contribution, supplies the brainstem in the posterior fossa of the calvarium and is very important. Now, to focus on the spinal cord, which is represented in green here, the cord is large in the cervical region where you have the cervical enlargement for the arms and hands, the appendages, and then it becomes a little more difficult to see as we drop down here. But as I move the cord laterally and lift it up, you can see that down in this region here, they've added the spinal nerve to each segment. And notice that the nerves come out between a notch in each of the vertebrae. There's a dip in the bottom one and a disc-shaped semicircle in the upper one, and together they make the intervertebral foramina through which the spinal nerve emerges. And sitting in this foramina, not demonstrated here, is the ganglion where the sensory cell bodies of the nerves carrying sensation are located. In between the vertebral bodies, here on the anterior surface, are the discs. These are the discs that so many people have moving in one direction or the other, herniating. They can herniate posteriorly, anteriorly, and as they move toward the central canal, they put pressure, I'll just pretend to herniate here, they put pressure on the spinal cord. And if they put pressure on the nerve here, then people have either pain or partial paralysis, or both. So the relationship between the vertebral column, the discs, the emergence of the nerves, and the foramina through which they emerge is very important. Now let's look at a gross specimen of the spinal cord. So I have here 6 spinal cords laid out from rostral, or near the cervical end, to caudal, near the sacral end on this tray. And the first thing I want to tell you is that the spinal cord does not come cut into little pieces like this. This was in the process of the pathology review of the spinal cord that the attending person cut it to look at it, to examine it for any pathology. So the spinal cord is not in segments, but is all connected like this. And these cut marks do not represent different spinal cord levels. They're totally arbitrary, as if you were cutting salami for dinner. Now, let's look at the outside. Remember, the dura covers the outside of the spinal cord. And here on the outer surface, we see these bumps. And there's a little bit of fat with them. But these bumps, there should be a pair on the right and left sides at each level. Those are the dorsal root ganglia. These are where the spinal nerves are emerging on each side of the spinal column. So there is a pair of dorsal root ganglia. Now, dorsal root ganglia, a ganglion is a collection of nerve cell bodies outside the central nervous system. These cell bodies have one process or axon that goes out to the periphery, to a sensory organ in the skin. And the axon then comes into the spinal cord to carry on and carry the information up the spinal cord toward the brain. Or there is a cell body in the spinal cord whose axon emerges in the spinal nerve and goes out to innervate the muscle. So the dorsal root ganglion is sensory, but passing through this region here are also the motor fibers. So we want to keep in mind that each of these represents a level. Now, I can't tell you exactly where, but this is approximately one segment of the spinal cord. Let's say it's thoracic, and this would be thoracic 1, thoracic 2, thoracic 3, approximately like that. This is the cervical region of a spinal cord, where in the cervical region, so the brainstem would be in this direction, and here on the dorsal surface you see a groove, and emerging in that groove are all these little rootlets. These are dorsal or sensory roots. You see all of these. All of these would be coming in over one spinal nerve. So on right and left sides, you have the filaments or the rootlets of the dorsal side. Now if we turn it over, so that's sensory. Dorsal is sensory. Dorsal is also called posterior, and we use those terms interchangeably. So these are dorsal roots or posterior roots. And if we turn it over, it's harder to see on this side, but most of them have been torn off in the removal of the cord. But on this side, you can see the ventral roots. These are coming out on the ventral surface, and they are motor fibers going out to muscles. Unfortunately, most of them are missing. Here we are in the cervical region, and let's magnify this as much as we can so that I can show you that there is gray and white matter in the spinal cord, just as there was in the cerebral cortex or the brainstem. The white in the middle is the gray matter. It's backwards, I know. And the beige on the outside is the white matter. So the white matter is in the dorsal region or posterior region, in the lateral region, and in the anterior or ventral region. And dorsal part of the cord was where the sensory fibers were coming in, and the ventral part of the cord is where the motor fibers were going out. And there is sort of a butterfly pattern. And at each level, this is the cervical level, so there's a lot of gray, or white in this case as it appears, cells, because we have so many muscles to innervate in the hands and in the arm. If we look now, let's say, at the thoracic level, where all you have are a few intercostal muscles, then you can barely see, you can barely make out any neuronal regions, any of the white H or butterfly pattern. It's very, very difficult to see because there aren't very many neurons, because we don't do very much with our intercostal muscles, unless maybe you're a belly dancer. And as we move down farther, down toward the sacral region and the lumbar region, then, because we have lots of muscles in our legs to be innervated, again, we have more of the white area, which is the gray or anterior horn, and posterior horns, as we call them, because of the shape of this H. And the dorsal or posterior is going to be sensory, and the ventral or anterior is going to be motor. And then finally, we get down to the very, very sacral region, where it's almost all gray matter. It's almost all white. And you can see that we have a lot of cells that are involved in the innervation of the sacral region. This model of the spinal cord can show you things that we were not able to see in the gross specimen. However, it gives you an exaggeratedly large impression of the spinal cord, and I wanted you to see how narrow and tenuous and delicate our spinal cord really is. So let's just recap very quickly. Let's focus on the upper model here, because it shows us, first of all, a spinal nerve, and this is the bulge of the dorsal root ganglion, and here is the ventral roots coming and passing through and joining in the spinal nerve, and here are the dorsal roots that are passing through with the cell bodies in the dorsal root ganglion. So this spinal nerve has sensory and motor fibers. The motor fibers are in the ventral or anterior roots, and they are actually leaving. Their cell bodies are in the spinal cord. Remember, this part of the spinal cord has the cell bodies, and the axons go out, and they carry on out to the muscle. Or if they're autonomics, they're going out to the smooth muscle. And these axons are dorsal roots. They are coming in, and they are connecting in the gray matter here and forming tracts out here in the white matter. So we have tracts, anterior, lateral, and posterior tracts that are carrying information up and down the cord. So they're going up and down, and we have roots that are coming in at each level that are coming in laterally. So the superior or posterior part of the spinal cord, the gray matter here, is particularly sensory, and the ventral part or anterior part is motor neurons. And in between, of course, are other neurons that we will not focus on. So damage to this part of the cord would give you a paralysis of the muscles innervated by these axons, and a compression of the roots here would give you a sensory loss for the segment or the dermatome of the body supplied by these axons. And so this is the segmental nature of the spinal cord. Each segment has a dorsal and ventral root. So this model really represents two segments of the spinal cord. Now, important in understanding the function of the spinal cord and in clinical testing is the fact that we have reflexes. A reflex is an automatic response to a sensory stimulus. So if a sensory stimulus comes in over this root and it makes connections with the nerve cell body in the anterior region here, and those roots come out and go to a muscle, you have a reflex, sensory in and motor out. And there's only one connection between the axon coming in, connecting with this neuron, and this neuron coming out. That is what we call a monosynaptic reflex. One synapse, one transmission junction, and so they're very fast, they're very automatic, and they need no thinking. So if you touch or pound on with your reflex hammer the nerve that supplies the region of the knee, or you pound on the tendon that is supporting the muscle, let's say at the patella, then the information comes in from the stretch of that muscle and tendon and causes a reflex jerk so that you don't overstretch your muscle, and the knee jerk reflex or patellar reflex occurs. So each segment of the spinal cord has a reflex associated with it. And there are some reflexes that are more commonly tested than others. And that patellar reflex is the most classic, but they are all monosynaptic reflexes. And they provide information about the level of the spinal cord and whether it's a sensory loss or a motor loss or both. And the absence and presence of reflex are very important clinical signs, not only in the spinal cord, but also we're going to see in the brainstem. Now, to relate this model to a stained cross-section of the spinal cord, This happens to be cervical spinal cord. Just want you to see that many times in teaching neuroanatomy, the cord has been cut and it has been stained. And we have special stains for the axonal myelin, the insulation of the axons that are carrying information over long distances. So the axons, or the white matter, remember, are on the outer part of the spinal cord, and the cell bodies, or the gray matter, are on the inside of the spinal cord. And this is where we get this sort of classic H pattern. Some people call it, in some regions, it looks more like a butterfly. So these are the cell bodies. So when we talk about a reflex, sensory information comes in, synapses on a neuron here, that neuron sends its axon out to the muscle, and that's all there is to a simple monosynaptic reflex.
Excellent. So she's really great, isn't she? So let's go ahead and check out the link that I posted for you. And you can check out any of her videos. There's a lot of them. So we'll look at cranial nerves again when we go through that lesson. So that concludes this chapter. I will see you for the next one.